If you were recently a patient in a hospital, you may not have even seen your primary care physician there.
Instead, a hospitalist, a physician who specializes in hospital medicine, may have been responsible for your care.
So we will discuss the role of the hospitalist on this edition of Health Talk. Stay tuned. Hello, I'm Dr. Eric Baser. Today we're going to talk about the role of the hospitalist. Joining us is Dr. Natallia Abramovich, a Norwalk Hospital hospitalist.
Welcome, Natallia. Thanks so much for coming back to Health Talk.
Thank you for having me.
Great to be back.
So Natallia, you're relatively early hospitalist. I think you started during the beginning of the movement, but people still are confused as to what a hospitalist is. Tell us about it.
I hear it every day in my practice. Patients still ask who the hospitalist is.
And where's my real doctor?
And where's my real doctor, or where's my own doctor? And a hospitalist is a doctor who specializes in a hospital medicine, practicing internal medicine, which means taking care of adult patients in a hospital setting. Since nowadays patients are more complex, higher acuity of care, there's so much going on in the hospital doctor is there all the time and can address those issues in a timely manner. So they can do the test, follow the test, might even see patients a few times a day, coordinate the care of every patient with other subspecialists, including the primary care doctor. And our goal is to keep the primary care doctor informed.
And just to have said it, you know, given what people are concerned about, a hospitalist is an attending physician, is a real doctor, is a fully trained, independently licensed.
You're not a resident or an intern.
Not a resident, not intern. Every intern and a resident actually supervised by the attending physician, fully licensed internal medicine doctor. And our internal medicine training, actually residency, is 2/3 of the time residents spend in a hospital. So they do have lots of experience in training, practicing hospital medicine.
So the hospitalists not only take care of patients, is what you're saying, but they're teaching the next generation of doctors.
And that was probably the reason why I chose being a hospital medicine doctor, is a heavy, focus on teaching, education, raising new generation of doctors, and providing them balanced training and balanced education.
And one of the interesting things in the teaching setting is that as a hospitalist attending physician, senior physician, you are there all the time to supervise the residents. And just to go back to the way it used to be, if your primary care physician admitted you to the hospital, that primary care physician would round in the morning, maybe in the evening, but then be in the office all day. So if a question came up, the intern or resident was on the phone trying to track down the primary care physician. It was a cumbersome process and often led to delays in care. Now with hospital medicine, you're there. You can be available.
Readily available, and available to the patient as well as available to the residents. And because it's very dynamic, tests are coming, results coming up, they can be addressed right away. And the steps in the management can be taken right away. Consultants can be consulted right away. Again, so it's more timely health care.
Maybe you could even give our viewers a practical example of that. So say, what might happen in a day in your practice? You've seen a patient in the morning, and then you order, say, a CAT scan or other test. What happens for that patient in your practice in the hospital?
A very common complaint patient comes with a shortness of breath. And sometimes it's not obvious what it could be. So we do multiple tests, which could be chest X-ray, and we review the results right away ourselves. We also can go and talk to radiology attendings and see what the next test will be. And it could be CAT scan. The CAT scan result comes back. We know the result right away and can address the concern. It could be fluid in the lung, could be clot in the lung, and we can start treatment pretty much immediately.
So you're not stuck to that morning rounds, evening rounds paradigm, which is really the way it used to work.
And also interact with other specialties as much. Radiology could be one example, as I said, when we discuss what is the best test for the next step in evaluation of the patient.
Absolutely. And because you're there to get that information at, say, 1 in the afternoon, rather than waiting till you come back from the office in the evening, if you need another specialist, a cardiologist or a pulmonologist, a heart doctor or a lung doctor, you can call them in pretty quickly to help you address that patient's need.
So the hospital doctor is not only just internal medicine doctor, it's also captain of the ship or captain of the team. We work as a team, and nowadays medicine is a team sport.
Yeah, no, I think
and coordinating the care, including other subspecialists, is super important. So there is one doctor in charge who can coordinate the care. Subspecialists, nurses, case managers, respiratory therapists, physical therapists. It's a multidisciplinary approach.
Absolutely.
So this is a nationwide phenomenon, and I think reflects a change in medical practice across the country. And we have a slide that we'd like to bring up just to show the growth of this specialty, which almost didn't exist at the turn of the century. 2001, there were less than 2005 or 3, whatever that is, there's less than 10,000 hospitalists. Now there are 50,000 to 75,000 hospitalists practicing. What do you think are the forces that resulted in this need for hospitalists nationwide? This isn't just Norwalk Hospital or Danbury Hospital or Hartford Hospital. It really is a nationwide phenomenon, and yet the term wasn't even coined until 1996.
Yeah,
so
I think the name of the hospitalist came up in 1996. Our own hospitalist program started in 1999, so we have very long tradition of hospital medicine at Norwalk Hospital.
And now we're virtually, what did you say before the show, 75% of hospitals across the country have hospitalist
That's
programs?
very true. 75%, the majority of the hospitals across the nation have hospitalist program as a main force delivering care in a hospital setting. And it's not just about only internal medicine hospitalists taking care of adults. There are hospitalists who are taking care of kids, pediatrician hospitalists. We also, in our own hospitals, we have pediatrician hospitalists as well as GYN hospitalist or OB hospitalist, so doctor who specializes in their care in a hospital setting as well.
So what do you think are the forces that have really created the pressure for such a major transformation in the way we take care of inpatients?
There is also major pressure on outpatient doctors. They have to do so much, taking care of the patient population, coordinating the care in a very high volume of the patient's visit. And having the hospitalists taking care of the acutely ill patients, they can focus on outpatient practice and deliver and see more patients a day and be more available to their own doctors. So it's actually good not only for inpatient patients, but also the patients who come to see their own doctor in outpatient practice.
I think that's really important because in the prior traditional model, if you were taking care of patients in your office but you had a hospitalized patient, if there was an urgent issue with your hospitalized patient, you would be getting a call which would take you away from your office patients, which would introduce delay or make it more challenging in the office as well. So,
and even to take that further, the days of I'll meet you in the emergency room, primary care visit, are not that far away. So the primary care physician used to have to drop everything, not leave his or her patients behind, meet their sick patient in the emergency room, take care of that, and then run back to see their patients. It was a tremendous dichotomy of responsibilities, and I think that in this era we're expecting more access to primary care and more availability of primary care physicians and more productivity, seeing more patients today. And when I started training, the internist would come in and spend the entire morning rounding on their inpatients, 3 or 4 inpatients, and then see a dozen patients in the afternoon. That doesn't work anymore. They can't make a living that way.
Patients also get more complex. People live longer. We take good care of them, and it's not unusual to have very elderly patients in our hospital, and they have multiple problems.
I think that's such an important point.
There are lots of new medications, there are lots of new technology, new procedures, new tests available, and it became a subspecialty. It's actually American Board of Internal Medicine recognizes hospital medicine as subspecialty nowadays, and people can be certified. So it's really becoming a different specialty. It's a different specialty.
And I think that's really, hopefully people at home understand that. It's not that your primary care physician doesn't care about you anymore or doesn't love you or is a wonderful
doctors in the community. We try to communicate at all means as a minimum primary care doctor contacted at admission and discharge, and we use all the possible technology, including autofaxing of the paperwork, history and physical, discharge summaries, which is done within 24 hours on discharge, so information is readily available.
And we understand that that's not perfect yet. I think
it's not perfect.
Because whenever there's a handoff, there are always things that may be missed.
And direct communication, nothing can replace direct communication. Some of that is also based on technology. We use special program texting, Tiger texting, which is HIPAA compliant, protects private information, and we can exchange information with doctors. And the best way is still pick up the phone, call the doctor, have a conversation about the patient, and we value primary care physicians input very, very much because
Absolutely.
they know their doctor, the patients best.
Right.
And that's something you can actually ask your hospitalist too, that if you get in the hospital and you see a strange face oftentimes, have you spoken to my primary care physician? Did they tell you about this? Did they tell you about that? Because I think that it's important for the patient to involve themselves and assure that that communication takes place, as well as important things are transmitted.
Absolutely, in both directions.
In both
from
directions.
the primary care doctor and then from the hospitalist back to the primary care physician as well. And you know, talking about some of the factors that drove the development, you alluded to it, but patients in the hospital are much sicker overall than they were
we say that all the
ago.
time, and people at home may not think that's true, but what's really happened is we don't admit a lot of the less sick patients anymore.
Less sick patients sometimes get admitted just for one day. We call it observation. Just come, observe, take care of the problem, and go home. There are lots of really sick people, and even on my watch last 10 years, some conditions we used to treat for 2 weeks now being treated for 3-4 days. So it's much more intense care, and lots of care gets
and part of this is driven by the insurance companies and by Medicare, and part of it is because we like to keep people home when we can. But I remember
part
even
of it is evidence. We used to. My understanding is that patients used to often come into the hospital before a colonoscopy.
I was going to say that. We
For
used to
their
bring
prep,
people in
right?
before barium enemas for 2 or 3 days to clean them out and give them IV fluids. That was pretty easy to care for that patient. That patient would not be allowed in the hospital now because the insurers won't pay for it.
And it's not necessary.
And it's not necessary, and it's
safe to
probably
do it
more
at home.
dangerous to do it in the hospital.
Because there is new technology, there is new equipment, there are new things available in medicine which were not available at those times.
But it does mean that more moderately ill patients are really being taken care of in the outpatient setting. So those patients are going to their primary care doctors, and the primary care doctors are now taking care of patients who are more ill even in their
Compared
setting.
to those
In a larger volume.
And they need really time in the office to really take appropriate care of those patients. And you need the flexibility of someone who's there in the hospital all day to take care of the really sick patients in the hospital.
And as a part of the being doctor in a hospital, not only we take care of the patients, we also take care of the processes in a hospital, safety,
which have become
quality.
very much more complex. Tell us a little bit about that.
So safety, quality, developing protocols to make sure the care is standardized and delivered highest possible care, regardless who is taking care of the patient, because there are protocols, safety protocol, as well as different disease-based protocols in a care. So, and we're not only looking at that, is transitions of care. It's very important. So work, as you said, communication with the doctor, primary doctor is a key, and we're working to improve on those processes. So when you become integrated into the hospital medicine and coordinate the care, we have time to address those issues, because the doctor in the community is just too busy for that.
And they don't have
available.
the experience for that either.
And the
how many
experience
patients
plays
do you care for on an average day who are in the hospital?
We have different doctors who work either 8-9 hours or 12 hours, and on average they take care of 10 to 15 patients.
And the average internist in the old days might have been caring for 2 or 3 patients who are not as sick, so that you get so much more experience at effectively and efficiently using hospital services than somebody who does it sporadically and is trying to balance that with their office-based demands. This is not to take anything away from primary care physicians, it's just to point out that it's really become a different specialty, a different practice environment, and there are so many demands in both settings that to try to do both can be very, to do both a little bit rather than to do one a lot is not as effective.
Increasingly challenging.
very, very. So we're going to talk more about this when we come back, but I think it's really important for people at home to understand hospital medicine. So we'll take a short break and be back to talk more with Natallia Abramovich about this important topic.
Stay tuned. Welcome back. We're back with Dr. Natallia Abramovich. She's the Chief of Hospital Medicine at Newark Hospital. Welcome back.
Thank you.
So Natallia, we're talking about some of the benefits of the hospital, of the hospitalist model. I think people, though, are really still uncomfortable. Their primary care doc isn't there. How can patients assure that they get the best care from a hospitalist? What should they be? How should they be interacting with this person? What information should they bring to the table? Et cetera, et cetera.
We have actually very sophisticated patient population, and I've seen it many times, and that would be tremendously useful. When the patient comes in, they bring the list of their doctors they usually follow with, primary care doctor name, any subspecialist who takes care of them, like heart doctor, lung doctor, or cancer doctor, because this plays a major role in their hospitalization.
So that allows you to then contact that same
doctor.
And
that allows to contact that doctor immediately and inform them about a patient being admitted and discuss the care. We are not doing the care in isolation. We work together. And list of medications, that's super important. So that is the most valuable information. And once this information is provided, it's a very legitimate question from the patient. Have you contacted my doctor so-and-so? And I expect our hospitalist to do so on admission, to contact subspecialists who are involved in the patient care. Those, like I mentioned, lung, heart.
So it's okay for the patient to ask those
questions.
Okay They're
to
not
ask.
Going to offend you.
Not going to offend us, and we're supposed to do it. And that's very reassuring. At least I always tell the patient, who's your primary care doctor? They tell me it's Dr. Heliotis, for example. I say, like, okay, I'm like Dr. Heliotis, just working in the hospital. We're going to contact him, and that's what I know about you. And I usually contact them even before going in, review the records, review all the information. And I tell the patient what I know about them, what else I need to know, and what they want me to address with their primary doctor. So it should be bi-directional communication, not just doctor tells patient what to do. We actively involve patients and as well as their families.
I was just going to mention families because they're so important in a hospitalization in any aspect of care.
And this is an area where a hospitalist can be so much more available than somebody from their office.
And another thing is, like, it's probably not well advertised. We can advertise it even more right now. When patients get discharged from the hospital, they get lots of information, and I truly understand it's overwhelming. Being in a hospital, it's stressful time for the patients and the family, and I want them to know they can still contact us even they left. Like the first couple of days, we probably know about what happened in the hospital, and if they have any questions, they can call us, our hospitalist office, which is 203-852-3019, which is available on the going to be discharge instructions. Contact us if they have any questions about medications.
So you're not like this when the patient walks out the door?
No, we want to take care and assure this transition between inpatient and outpatient.
And we recognize, I'm sure you recognize, everyone recognizes that those transitions are vitally important and that things can be messed up during those transitions. So it really takes a lot of extra work to make sure that those happen smoothly and completely.
Crucial times.
Let me ask one other question. The hospitalist that the patient sees may switch on the next day or the day before, or the 2 days in. How do people react to this? Get a sense that they're in an assembly line, that there's nobody really looking out for them. Tell us how we assure that their care is being maintained over that continuous time.
So not only we have doctors taking care of the patient, we also have physician assistants, we have residents, and they continue to follow those patients. So there is always someone on the team who knows. On the other hand, the same transitions of care, issuing sign-outs. We write in letters to each other about the patients and telling about the problems, what needs things to be followed up on, to make sure the patient gets everything what they need while they're in a hospital. Yes, it's a complex environment, so many people involved, and we expect the physicians to know about the patients. And as I said, like I always introduce here is what I know about you if there is something else, and my partner so-and-so is going to take care of you tomorrow, and I'm going to pass that information. As long as we do it all the time. I think we don't always communicate with the patients and the families that we do, so we need to pay more attention to that.
I think that's important to highlight is that the way it's structured here, and different hospitalist programs run differently across the country, but I think in the Western Connecticut system, hospitals really are partners with each other. It's one group, and there's a lot of interdisciplinary and within the hospitalist group communication, isn't there?
And the other thing that I think maybe again for people at home to understand, we spend a lot of time on computers, but they really haven't reached their potential in terms of providing access to everybody for all information. So the doctor and in his office, the primary care physician, or her office, the primary care physician, that computer record may not talk to the record at the hospital. So there's really a lot of work that has to be done to make sure that information is communicated.
And it's already been done. As I said, like as long as the patient who comes to the hospital provides name of their physician, and it not only affiliated with Norwalk, it could be doctor in Darien, could be doctor in Stamford or Bridgeport. As long as the name is in the system, those doctors are going to receive at least 2 fax, which are auto-faxed, which history and physical means initial visit note and discharge summary. So ensure not only doctors affiliated with our hospital receive this information, but any doctor who is identified as a primary.
We have a little under 2 minutes left, remarkably, in this segment. Maybe you can mention a few other of the quality initiatives you alluded to in the first segment in which hospitalists are really involved, because I think it's important for people to know.
And even safety, too.
They're really involved throughout the hospital in very important things.
That can be any protocol, like, DVT prophylaxis of the clot, which is a common problem in a hospital setting, especially in acutely ill patients or after surgeries. So we develop protocols, we monitor compliance and make sure people do it.
You're talking about the hospitalist group.
I mean the hospitalist group together with information technology people, IT, we work very closely because when you develop the protocol and guidelines, it helps decision making, not just information there. It supports the physicians throughout the hospital stay.
And you can hold each other accountable.
We hold each other accountable. We also participate in other, antibiotic use, blood use, product utilization, different committees looking also at the patient experience. The hospital is pretty much represented in any hospital committee. So our voice is heard, physicians' voice is heard, but also we always advocate for the patient care. The best possible can be done. Plus teaching. Our hospital is a teaching facility, so we do lots of teaching students, teaching residents, and that's essential part of our day as well.
How much of the decision making do you share with the primary care physician in the office, and how much you do on your own and let that person know afterwards what's happened?
It depends on the problem, because there are acute problem, new, very fresh, primary doctor is not aware of. Decision needs to be made right away, and problem has to be taken right away. Versus it's an exacerbation of the chronic condition, and we need to gather that information, evolution of the problem, and how patient responded to different treatments in the past, because we don't have to start everything from scratch. We need to take that in account.
So this really is, again, reflects the team approach to care, which is part of modern medicine. I wish we go on like this for
hours,
I think we can go for
a long time because we do that.
I want to thank you, Natallia.
Thank you.
And when we get back, we'll have today's health question.
Right now, let's take a look at some of the upcoming events sponsored by the Western Connecticut HealthTalk.
Hi, this week's viewer question is, what causes ulcers and how can they be prevented? We have 2 internal medicine specialists here along with me. You want to take a stab at that? What causes ulcers? It's changed. It hasn't changed what caused them. Our understanding has changed
I assume
dramatically.
we're talking about peptic ulcer disease, like ulcers in the stomach or duodenal intestine. Interestingly enough, people think it's stress-related, pressure, whatever. It's infectious disease.
Amazing. It's an infection.
Yep. It's an infection which can be eradicated, treated, and cure it.
So how do you know you have that? It's Helicobacter pylori or H. pylori. How do you know you have that infection?
It could be direct, biopsy when people have endoscopy looking at their stomach. It could be just as a stool test nowadays. It's very easy to detect it.
But you may have no symptoms until you have an ulcer, right?
You may have the organism within your system, but it may be not causing any
So
problems.
this isn't like the flu or a strep throat. It just sits in your stomach and may or may not cause problems, but when it does, it can be an ulcer.
It does.
And so you treat, I remember the old days of drinking milk and milk of magnesia and all that sort of stuff. Now how do we treat ulcer disease?
3 antibiotics and plus antiacid medication. So it's 2 antibiotic and antiacid medication. We call it triple therapy.
And it's really sort of amazing. What used to be, there was surgery for it, and you were supposed to cut down on your stressful lifestyle, has turned out to be a relatively simple to treat infection.
I think like for that particular cause, it's very few surgeries nowadays are done.
Absolutely, and just such a revolution in how we think
really
about
is. So, and this goes on with medicine.
Condition.
We're understanding things more and more. This is a fascinating subject. It's certainly changed in my lifetime. Thank you both so much.
You're welcome.
Appreciate it.
Thank you.
If you have a question at home that you'd like to ask on Health Talk, please contact Andrea and me at healthtalk@wchn.org.
We'd like to thank our guest, Dr. Natallia Abramovich, for coming on our show today for this really important discussion about hospital medicine.
So we'll see you next week on Health Talk.
Stay well.